Babies, I believe there, if we have time, we'll do that today. If not, I'll get it at another time. That's a pretty quick one. All right, so viral stuff. We're going to talk about herpes simplex, herpes zoster or varicella, molluscum, verruca. There's a few HIV-related things. That's not on our blueprint. I just thought it might be good for you to know a couple of these. There's a few extra things in there that I'm going to have you not even worry about, just completely ignore. But I'll point those out to you and share that with whoever we can here. Okay, so herpes simplex. Yeah, I'm not going to go into humongous details because I know you probably did with gynecology or whatever. HSV1 has primarily been associated with orofacial. HSV2 has primarily been to the genital area, but now it's kind of all over the place, and I'll let you use your imagination to figure out why that is. Most adults have antibodies to HSV1. Okay, most of us have been exposed to that, and we have antibodies to that. So once we get herpes simplex, we never get rid of herpes simplex, right? It just stays in our sensory nerve, and it will reignite periodically. And the frequency of that can vary from person to person. It can be never, it can be very infrequent, or it can be very frequent. Typically, HSV, you don't even realize when your first infection occurred because you're asymptomatic. Every now and then you can kind of have a pretty vigorous reaction, and you get a number of lesions, painful lesions in the mouth and fever, yuckiness, but most of the time you don't even know you were infected, and your second reoccurrence is a reoccurrence, not your first exposure or first presentation. This is another one of those things, zinc smear. You have to know zinc smear. I have never ever done a zinc smear. You will never ever do a zinc smear, but you have to know it for your test. All right. For testing HSV versus varicella, I did the PCR. Now you can do a viral culture. They have their own swabs versus a bacterial culture. You're going to get a viral swab, and you're going to, you need to kind of break open that blister, and you kind of need to dig at the, grind that culture swab into the very base of that blister. That is where the greatest amount of virus is going to be. You don't want to get an old crusted up lesion, because that the likelihood of getting a false negative is pretty likely. So the negative to the viral culture is they grow that bacteria, and it takes weeks for the results to come back. The DFA and the PCR you can get in several days, so that's more what I will do. All right, the textbook description for this is grouped vesicles or pustules, okay, on an erythematous base. And oftentimes it can be pustules. So pustules doesn't always indicate bacterial infection. This is a grouped, okay, that's kind of key. You're going to get a number of vesicles or pustules all grouped together. Oftentimes in the groin area, the blisters are going to be well unroofed, and all you're going to see is a little scalloped border. An erosion with the little scalloped border where that cluster of blisters were sitting there together. Okay. Now on the lip, you may actually see that little cluster of blisters, or it may have already crusted over. Treatment depends upon how frequently you get this. You have intermittent treatment where I will give a person, several treatments in a bottle and just say, take this on every trip, keep it with you. And at the very first sign, typically, I guess I don't have that in here, typically before you even get the blisters or the pustules, you get this sensation, a tingling, prickling, burning sensation to the area even before you see the blister formation. So you tell, and people who experience this on their lip, they know exactly when they're about ready to break out. So you say, as soon as you get that first sensation that you're going to get a breakout, get on this medication. And then there are some chronic suppressive treatments where if they get these, every month or every other month, you can give them a pill every single day to prevent the outbreaks or as many outbreaks. One important thing to note too is that a person who has herpes can give this to somebody else even when they are not symptomatic, even when they don't have blisters. That is viral shedding. And chronic suppressive therapy reduces that viral shedding by 95%. So that is good to know. So you need to educate your patients that they could potentially share this with their partner, even though they don't have active blisters. Now, what encourages it to flare up? Sunlight. Okay, sunlight. Stress, other infections, other viral illnesses. People who have procedures, laser surgery, dental procedures, things like that for the oral labial, it can flare that up. So you oftentimes will treat them prophylactically to prevent that beforehand. There's a few variants of herpes simplex virus skin infections. Herpes gladiatorum. Okay, this you're going to see in your athletes, especially your wrestlers, and I have seen this where they have a widespread involvement. Face, chest, ears, arms, hands. I've seen this, and the picture in here looks just like what the young man that I saw. Herpetic Whitlow is when you have HSV of the finger. And then you can have widespread dissemination of this virus in the immunocompromised. I had a gentleman who was on methotrexate, long-term methotrexate for rheumatoid arthritis, and he came in with, it wasn't widely disseminated, but he would get it on his arms, and it looked just like folliculitis, but it was probably non-folliculocentric. Alright, that's the picture of the zinc smear, that giant multinucleated cells. That's another term you need to know. That's what you're looking for with the zinc smear. And that's the oral labial presentation of a cold sore, herpes, a cluster of vesicles on an erythematous base. There it is on the penis. There it is on the labia minora. Again, you don't see blisters or pustules there. They have already ruptured, and that's almost typically how you're going to see it, but it has that kind of scalloped border. I have seen herpes simplex all over the place. I haven't seen it on the scalp. I've seen it various places of the face, not just on the lip. I've seen it on the finger. I have seen it belly. I have seen it tush. I have seen it legs. It can be anywhere. If you get a cluster of blisters that and this has happened in the very same spot before, it's got to be this. Okay. So, when next time you flare up and you have blisters, make an appointment so then I can culture it or I can see it when it's active. Herpetic Whitlow on the finger there. And then the gladiatorum, and that is exactly what my poor patient looked like. Widespread herpes on his face. That is a bummer. And here is more disseminated in an immunocompromised person. Zoster, herpes zoster, again, chickenpox. That chickenpox virus, the herpes zoster, just lays dormant on that nerve root, and you become immunosuppressed, you get sick again, and age, just being over 60, puts you at a lot greater risk of getting reactivation of this virus. Again, preceding pain, and you're going to hear this, and this pain could be kind of a mild itching, tingling sensation to a very deep, boring, burning pain before you see any rash at all, and that will give you tons of information. If you see a little bit of redness somewhere, you know, that you're kind of suspicious for, and they're complaining about pain and deeper pain, then you got your probable diagnosis. All right, grouping of vesicles, pustules, and sometimes they can even be hemorrhagic, look bloody, like a bloody blister. That's pretty common in zoster. And again, it's going to be unilateral, only on one side, and whatever area of skin that nerve root provides sensation to. Sometimes you can get the neighboring nerve root or two, so that is not uncommon. The most common is in the thoracic area, followed by the trigeminal. The trigeminal nerve, and here's a couple little key things I need you to know too. The trigeminal nerve, as you remember, has 3 branches. The ophthalmic branch, and so a person will break out with the herpes up above the eye, but it can affect the eye and can cause blindness. So whenever you see suspicious herpes zoster to the forehead, you need to get them to see an ophthalmologist ASAP. Don't just say, I think you probably should see an ophthalmologist and leave it in their hands. No, you go make them an appointment and say, okay, you're going over there this afternoon. All right. Now, what's especially telling is if you have blisters or vesicles on the tip of the nose or the side of the nose. If you see that, you got a pretty good indication that the eye will be involved. Okay, now I'm not going to wait until I see blisters on the tip of the nose. If I see it anywhere in this trigeminal nerve, they're going to see an ophthalmologist, because they need treatment with high dose of steroids. Okay, another variant is when you have involvement of that facial nerve. Yeah.
Do you start them on treatment, or do you just send them?
No, I send them over there.
Oh.
Now, I might start them on the antiviral, but I would get them over there ASAP. When you have facial paralysis, one-sided facial paralysis, with blisters involvement, of zoster involvement of the ear or the oropharynx, with or without tinnitus, or ringing in the ears, or dizziness and or deafness, that is called Ramsay-Hunt syndrome, and that is zoster. Okay. Again, you can have this widespread disseminated as well, and really the only way you're going to be able to tell whether it's zoster, disseminated zoster, or HSV is with biopsy or culture. Again, they've got a number of antivirals. I know Dr. Latassi will talk about those. You can always look up I can never remember the dosage, so I've got Hippocrates, and I will look that up. Now, the biggest complication, other than, you know, vision loss and that sort of thing, but of your run-of-the-mill herpes zoster is post-herpetic neuralgia. And that is inflammation, pain in that nerve root that is long-lasting. It can stick around for months to years. The elderly are the most prone to this. There are some medications, some of the nerve pain type of medications, such as gabapentin, things like that. Again, she'll talk about that. You want to, in your older, I'm not going to say elderly because I'm way too close to 60 years old. In your older population, you got to get them vaccinated for this. And this is textbook zoster. Here's the Ramsay Hunt. On the two on the left, she's got involvement in that ear. She has left-sided paralysis of her face or nerve. And then on screen right is disseminated. Again, disseminated immunosuppression or HIV/AIDS.
I know that's something that we typically see in older people, but a lot of people my age have been diagnosed with this.
Oh, absolutely.
And my friend was telling me her doctor was saying it was something to do with the fact that I grew up when we did get chickenpox, but then all the people just a little bit younger than me got the vaccine, so we haven't been exposed to it. So she was saying it's just this like 10-year portion of people who have a really high percentage of getting it young. Mm-hmm. Have you heard anything about that?
Absolutely. I mean, you see it in children sometimes, 10-year-old or younger. So anybody can get it. Now, I never really knew why a certain age group were more prone to it, so that's kind of interesting.
Yeah.
Makes sense. But yeah, the 60 and over are by far the most prone, but you can see that in any age group. All right, warts. I simply despise warts. Hate them, hate them, hate them. HPV, you know, there's over 100 strains of HPV virus. Who's lecturing next? Okay, let me see if she's out here. You guys just went to the bathroom, right? So you're okay. Okay, you've got different presentations of warts. Verruca vulgaris, you know, that's just your typical wart. Verruca plana is when they are more flat. They tend to have more of a brownish, light brownish discoloration, but they're more flat. Papillomatous is a term that, Verrucus papillomatous is that kind of that bumpy, real bumpy texture. And you kind of use that term synonymously. Verruca plantaris, that's on the bottom of the plantar aspect of the foot. And everybody's going to say, I think I got a plantar wart right here. It's just, that's just what they think. Plantar wart, it's called a plantar wart because it's on the plantar aspect of the foot. But everybody calls them plantar warts. And the other thing is the little black dots that you see in plantar warts are not seeds. Everybody calls them seeds, and but they are thrombosed little capillaries. They're very vascular. The warts are very vascular, so they bleed very much, and that's why. Because they got blood vessels running through there. You know, certain strains of HPV are known to cause cancer to the genitalia, vagina, rectal, nasopharyngeal area. They have the Gardasil and Cervarix, sorry about that. The HPV vaccine for the younger people. Warts are a booger to get rid of. Everybody wants them gone yesterday, and I would get more people mad at me over a damn wart than anything else. The cancers, they were fine with cancers, but you have a wart on their skin, and so they are just, there's 18 gazillion ways to try them, and to try to get rid of them. And that tells you that we don't have one really good way to get rid of them. They will go away eventually, but it can take years. Our body will eventually, you know, decide to fight them off. Okay, so salicylic acid, perhaps that's just, salicylic acid will help slowly peel that down, okay? You've got over-the-counter products, you've got stronger prescription products. Liquid nitrogen, you're basically freezing that so that it will blister up and peel away. Usually, though, one treatment doesn't get it. It will peel down, that blister will come off, it'll look like it's nice and gone, and then given several weeks, it'll be right back there. So usually with any wart, I will say, see you in a month, because we're going to have to do this again. Especially bottom of the foot, because they grow deeper and they're just horrible. Electrocautery is when you actually numb the area and burn it. And would you let me know if you see Professor Burke? I don't do that very often at all, because I guarantee you a scar. You're going to get a scar when I burn your skin, and I still can't promise I'm going to get rid of the damn thing. So then you're really going to be mad at me if I have given you a scar and your wart comes right back. Now, have I done it before? Yes, I have. If there is like a single 1 or 2 wart on the, the elbow where you don't care about a scar so much, but I certainly am not going to do that in an area where they're going to scar and let them know they're going to scar. Cantharidin is a blistering agent. It comes from a beetle. You're probably not going to see that in your everyday family medicine practice, but dermatology practices have that. It's not near as good of a blistering agent as your liquid nitrogen. I don't use it very often on your run-of-the-mill warts, but I use it a lot on molluscum contagiosum, which we'll talk about. Topical immunotherapy. This is where your body, you apply a chemical that your body is more than likely going to be allergic to, okay? And the more exposure you get to that, your body is eventually going to, it's almost like if you got a poison ivy leaf, okay? And I apply poison ivy leaf to a wart every day, all right? Your body's going to start reacting to that poison ivy, and eventually it's going to say, oh my gosh, there's a wart here, let's get rid of that too, okay? So, you know, though, that they're going to get a reaction. They're going to get itching. Some people will get an overreaction and will get that poison ivy-like rash to other parts of the body other than where you do that, so I just have to tell them. Intralesional candida, or bleomycin. These are injections of medicine right into the wart. Candida is yeast, okay, that people will give that sometimes to see how our immune system reacts, right under the skin, but it's been studied and it's been used in the treatment of warts. I have used that and it can work really, really well. Bleomycin is that cancer drug, okay? It works by 2 ways. It kind of disrupts how the virus replicates itself, and it kind of blocks blood supply there. That can work real well, but it's very painful. That's very painful going in. And they tend to get a pretty big blistering reaction, and it can be painful for a week or 2, especially on the bottom of the foot. I'm only going to use that because there's a little potential for scarring with that too, so you need to warn them about that. But again, you're not going to be doing that in family medicine. You're going to be referring that on to dermatology. And then their topical imiclomod is a medicine. It's primarily used for it's approved for genital warts. And it recruits your own immune system to the area and gets your own immune system fighting off that virus. It can work very, very well, but you have to apply it every day or at least several days a week. You have to be consistent about doing that, and the immune system's gonna get revved up there. So you're gonna get some redness and inflammation, and that's normal, all right? So those are various treatments. All right, here's Verruca vulgaris, that's your typical wart. I hate those around the nail bed. They are horrible. This are your flat warts, or Verruca plana. See how it's a little bit more brownish in color? And you can see on that little girl's, or boy, whatever it is, she just completely self-inoculated by scratching. just spread that little virus. You're gonna see lots of warts on gals that shave their legs. They're just spreading that virus all over their legs as they shave. And there's the dreaded plantar wart with the seeds. No seeds, I'm teasing. All right, molluscum. Is she out there yet?
I see a shadow.
Did you see a shadow?
You guys walk past it, but
Okay, well, I'm gonna keep talking. That's all right. Molluscum. All right, this is from the pox virus. This is another wart. Have you guys talked about molluscum? No. You're gonna see this all the time in kiddos. It tends to like flexural areas, bends of the elbows, armpits, backs of the knees, but it can be anywhere. These are very distinct in the way they look. They are sharply circumcised, tend to be dome-shaped, have kind of a pearly color, and umbilicated. They have a little indentation in the middle of them. All right, so know that description. They are contagious. Now, these are a little bit easier to get rid of than your typical wart, but they're more contagious. So again, you are kind of, it's a vicious circle. Plus, molluscum can get eczema flares in people that are prone to eczema. So you want to make sure you calm the inflammation down of the eczema, because if they're scratching their eczema, they're spreading that virus around. So you're going to get nowhere trying to treat the little virus unless if you control the eczema flare with a topical steroid. Okay, these again will go away on their own. If you've just got a few, I would just say don't worry about this. You know, it should go away on its own, but it may take a while. I use cantharone, that blistering agent from a beetle, a lot with these. You can freeze them. Curette, that is a possibility, and I've done that a lot. Especially, now, one thing I failed to mention, when you see this in the groin area in a teenager or an adult, that is an STD. That's sexually transmitted. But in an adult or an older child, you can plus or minus numb the base, use a small little 2 or 3 curette. Curette is a little looped instrument that's very, very sharp on one edge, and you just basically scrape that little lesion off. And they're going to bleed, so you have to typically we'll put some cauterizing substance on there to quit bleeding. Topical retinoids, like what we use, a retin-A cream that we use for acne, I will use on, like if they've got a few on their face and we don't really want to freeze or blister or put a blister on their face, I will say apply this at nighttime, or I'll use it in conjunction with our blistering agents. This is textbook. See that umbilication, that indentation there? It's kind of pearly, dome shape, and the screen right has that eczema flare around there. So you need to give them a steroid cream. Inform them. The steroid cream I'm giving you will do nothing for the little bumps. It's so that we can control that eczema so the kiddo's not spreading that virus around. Few HIV-associated things. The only ones I want you to know, Kaposi sarcoma, oral hairy leukoplakia, Eosinophils Folliculitis, and sepderm. Don't worry about the other ones. Kaposi sarcoma is a cancer, okay? It can be in anybody who is healthy. Classic KS, Kaposi sarcoma, is in a 60 or older Mediterranean or Jewish background, okay? But it's fairly common in the HIV population. Especially, you know, if you see something that's suggestive of KS, and you don't know they don't have a diagnosis of HIV or AIDS, then you need to ask about it or see if you can test for it. These tend to be red to violaceous. Violaceous, violet, purple, okay? That's what that term means. Erythematous to violaceous macules, a flat lesion that is progressing to a raised plaque or nodule. Okay, so red and red purpley color. Can be in the mouth, the hard palate, face and trunk are the main areas. You need to biopsy that. And those look more brown. In person, they're probably going to look more reddish to a deeper purple color. Oral hairy leukoplakia. This has to do with Epstein-Barr virus. Again, HIV immunosuppressed. About a third of HIV patients, or AIDS patients, sorry, they're more advanced, not just HIV positive, but AIDS. You get this poorly demarcated gray to white corrugated, okay, kind of wavy plaques on the lateral tongue. Leukoplakia you tend to think of as a precancer. In this instance, it's not a precancer, all right? You cannot remove that, like with candidiasis. Remember we talked about you can scrape off that white plaque type stuff. In this instance, you cannot. Usually asymptomatic, not pre-malignant, but if a person has it, it means they may be a little bit more advanced in, if they have HIV, may be a little bit more advanced in their process. And that's what that will look like. Don't worry about that, don't worry about that. Okay, this is another variant of folliculitis called Eosinophilic folliculitis. Very rare. I've seen one person with this. But this is a form of folliculitis that you tend to see more in the HIV/AIDS population. The only way you're going to be able to determine that is with a biopsy. All right? It tends to be very, very itchy, even more itchy than the pityriasis form. Okay? And you treat it differently. Yeah. Oh, she's here. Okay. Sebderm. I will talk more about sebderm later on in the week, I think, as far as what it is. But when you see, it's very prominent in the HIV/AIDS population. Okay, and it tends to be a much more widespread involvement, harder to treat. So when you see somebody with a raging sebderm case, you might ask about the possibility of HIV. Okay, that's mainly what I want you to know about that. And that is what it can look like. But I'll talk more about sebderm itself later on. Sound good? Okay, thank you guys.